Pulmonary tuberculosis is a contagious infection caused by Mycobacterium tuberculosis that involves the lungs. Pulmonary tuberculosis can be caused by Mycobacterium tuberculosis. This bacteria can spread from an infected person to someone else. Someone can get infected by breathing in the air droplets from a cough or sneeze of an infected person.
Tuberculosis may occur in three stages: primary infection, latent infection, and active infection. First is primary infection. To initiate infection, Mycobacterium tuberculosis inhales into the lung. In the early weeks of infection, some infected macrophages migrate to regional lymph nodes, where they access the bloodstream. Organisms may then spread hematogenously to any part of the body, particularly the apical posterior portion of the lungs, epiphyses of the long bones, kidneys, and vertebral bodies. Hematogenous dissemination is less likely in patients with partial immunity due to vaccination or to prior natural infection with Mycobacterium tuberculosis or environmental mycobacteria. Next is latent infection. Latent infection occurs after most primary infections. In about 95% of cases, after about 3 weeks of inhibited growth, the immune system suppresses bacillary replication, usually before signs or symptoms develop. Tubercle bacilli can survive in the material for years. The balance between the host resistance and microbial virulence determines whether the infection ultimately resolves without treatment, remains dormant, or becomes active. Lastly is active disease. Healthy people who are infected with tuberculosis have about a 5 to 10% lifetime risk of developing active disease. Although the percentage varies significantly by age and other risk factors, in 50 to 80% of those who develop active disease, TB reactivates within the first 2 years, but it can also occur decades later. In some patients, active disease develops when they are reinfected rather than when latent disease reactivates. Reinfection is more likely to be the mechanism in areas where the TB is prevalent and patients are exposed to a large inoculum of bacilli. Reactivation of latent infection predominates in low prevalence areas. In a given patient, it is difficult to determine whether active disease resulted from reinfection or reactivation.
The clinical manifestation for pulmonary tuberculosis is, for the early PTB, is asymptomatic. Bad cough for at least 3 weeks, chest pain, coughing up blood or phlegm from the lungs, breathlessness, weight loss, loss of appetite, nausea, vomiting, fatigue, fever, chills, and night sweat. Next, for the patient with a latent PTB, they need to take antibiotic, which is isoniazid, daily for 6 to 9 months. While for the patient with an active PTB, they need to take antibiotic, which is isoniazid, rifampin, ethambutol, pyrazinamide, for 6 to 12 months. In addition, they also need to stay at home or short hospital stay. The other way for treating the pulmonary tuberculosis is a directly observed therapy, DOT, which is an approach to ensure treatment is complete. For this treatment, a professional healthcare meets patient every day or several times a week to administer medication so patients don't have to remember to take it on their own.
For the prognosis, patients with primary pulmonary tuberculosis can be cured if they have been correctly diagnosed. The infection may be inactive and may be reactive for the patients who are recovered from primary pulmonary tuberculosis. Relapse rates are less than 5% with current regimens. The main cause of treatment failure is non-adherence therapy. TB is severe and often deadly disease without treatments. After 5 years without treatments, the outcome of smear-positive pulmonary TB or PTB and HIV-negative patients is as follows, where 50 to 60% die because of case fatality ratio for untreated TB. 20 to 25% are cured because of spontaneous cures. 20 to 25% develop chronic smear-positive TB. With adequate treatment, the case fatality ratio or CFR often falls to less than 2 to 3% under optimal conditions. Similar CFRs are seen with untreated ePTB and spear-negative PTB, with an equivalence fall in CFR with adequate treatments. Untreated TB in HIV-infected patients or not on antiretrovirals is almost always fatal. Even on antiretrovirals, the CFR is higher than in non-HIV-infected patients. For the reference, we refer to the books written by Nina Kowal CZYK and James D. Meese on 2009 about radiography pathology for technologies in 5 editions. Second, we refer to the articles that written by medicalnewstoday.com about what to know about pulmonary tuberculosis that written by 21 June on 2019. Third, we refer to the article written by Carrie E. that returns on 28 March 2018 about pulmonary tuberculosis hooks line in media. First, we refer to the MSD manuals 2021 that returns about overview of tuberculosis TB, MSD manual, professional editions. And lastly, we refer to the articles written by 1.4 Prognosis Tuberculosis 2021 by msf.org.